We were talking about the clinical manifestation of sarcoidosis, and most common respiratory complaints include cough and dyspnea. These are the most common presenting symptoms, followed by cutaneous symptoms and ocular involvement. Cutaneous and ocular. Cutaneous lesions, they are non-specific, which we will be discussing in details later. Non-specific skin lesions. Then non-specific constitutional symptoms like fatigue, fever, night sweat, weight loss. These are the clinical manifestation that we see in sarcoidosis. Now let us talk about the specific organ involvement, and we will be starting from lung, as this is the most common organ involved, and it is involved in more than 95 around 95% of cases. And most common method for detection is a chest x-ray, and the chest x-ray shows bilateral hilar adenopathy. CADing scoring system has been developed based on the chest x-ray. It was developed in 1961, which includes stage 1 to stage 4. Stage 1 include hilar adenopathy. Stage 2 include adenopathy plus lung infiltrate. Stage 3 include infiltrate alone, and stage 4 include fibrosis. Sarcoidosis has an upper lobe predilection, so it predominantly involves upper lobe, and there are only handful of non-infectious diseases which involves the upper lobe. The non-infectious diseases involving the upper lobe include hypersensitivity pneumonitis, silicosis, and Langerhans histiocytosis. The infectious causes with upper lobe involvement include tuberculosis and pneumocystis pneumonia. Around half of the patient have obstructive disease. Interstitial lung involvement may be seen, and pulmonary hypertension may be seen in less than 5% cases. Let us now talk about the skin involvement. Seen in around 30% of the cases. The various lesions include erythema nodosum, maculopapular lesion, hypo or hyperpigmented lesion, keloid, and subcutaneous nodule. Then there is a specific complex called lupus pernio, consists of involvement of bridge of nose, area beneath eye, and cheek. This is known as lupus pernio. Lofgren syndrome includes erythema nodosum, hilar and uveitis. Now we will talk about the calcium metabolism. There is hypercalcemia and hypercalciuria seen in around 10% of the patients with sarcoidosis. The mechanism include release of 125 dihydroxy vitamin D by granuloma itself, which leads to increased calcium and decrease PTH due to negative feedback. The serum calcium should be done as a part of initial workup of all the sarcoidosis patient, and it should be repeated during summer, as in summer there is increased sun exposure leads to increase vitamin D. If there is history of renal calculi, 24-hour urine calcium should be done. We will now talk about the eye involvement seen in 30% cases of sarcoidosis. Most common manifestation is anterior uveitis. Others include retinitis, pars planitis. Symptoms include can be asymptomatic, that is active inflammation without any symptom, photophobia, blurred vision, increased tearing, and can lead to blindness also in extreme cases, and there can be Zika symptoms also. Liver involvement, it is also frequently seen, includes granuloma, multiple granuloma, and most common abnormality in liver function is increased alkaline phosphatase. Elevation of transaminases may be seen And increase in bilirubin generally indicates advanced disease. Hepatomegaly can be there. Intrahepatic cholestasis, which can lead to portal hypertension, later on ascites and esophageal varices. Ascites and esophageal. Bone marrow and spleen can also be involved. Bone marrow and spleen. So most common hematologic abnormality we will see, it is lymphopenia. Anemia then is seen in 20% cases. Splenomegaly can be there in 5 to 10% cases. Then CT is relatively specific for finding out granulomas in spleen. And then biopsy can be done, bone marrow biopsy and splenic biopsy. It will show presence of granuloma.